Welcome everybody. Before we begin, a quick announcement. If anybody has any accommodation or access needs, please feel free to message the host, and we'd be happy to make this webinar a little bit more accessible for you. A quick disclaimer, the Connect to End COVID-19 initiative is supported by the Center for Disease Control and Prevention of the U.S. Department of Health and Human Services as part of a financial assistance award totaling $3.3 million with 100% funded by CDC HHS. The contents of those are those of the authors and do not necessarily represent the official views of or an endorsement by CDC, HHS, or the US government. Next slide, please. There we go. Just welcome everybody. Myself, my name is Victor G. I am with the API Social Work Council of Northern California, where I serve on the steering committee, and I'm the founder of our medical public health subcommittee. This is the second of a two-part webinar series and larger initiative to address COVID-19 vaccine confidence among API communities. As part of this, we're honored to welcome Dr. Brandon Yan, who has significant experience in this area, whom I'll introduce more in a little bit. For those interested in learning more about what we're discussing today, we have a lot of resources available, including the NASW website, where we'll be publishing our fourth and final article for the initiative, and links will be provided at the end of the webinar. I want to personally express my deepest thanks to fellow social work consultants on this initiative, including Ayaka, Anna, Jeff, and Kev, all of whom currently or have previously served as co-chairs for our Southern Council. It's really been an honor and a privilege to work alongside them. I also want to thank NASW, both California and national, who've provided invaluable support in the background, including Jane, Alex, Kimberly, and Sylvia. Next slide, please. Oh, okay.
So would you like to make an announcement about the CEU?
Yeah, of course. Thank you. So hi, everyone. My name is Sylvia. I am a program coordinator at NASW California. And just to echo what was said about the CEUs, if you are interested in obtaining 1.5 CEUs tonight, please go ahead and complete the survey. I did drop the link in the chat. You can also use your phone, open up the camera, and then scan the QR code, and it should take you to that link. Please keep in mind that if you do want your CEU certificate, you'll need to complete both the survey that is up on the screen now and the one that we share at the end. This one is the sign-in, and the one at the end is the evaluation. If you have any questions or need any sort of tech help or accommodations, please feel free to message me. But I hope you enjoy the webinar.
Thank you, Sylvia. Next slide, please. Thank you. Okay, so to briefly introduce our council, the API Social Work Council actually started almost 30 years ago, and it all started with a group of social workers from the SF Bay Area who began meeting in May of 1995 over concerns about the potentially devastating effects of the socio-political climate on all people of color, especially socioeconomically vulnerable API communities. Since then, our council has actually grown into 2 councils covering both Northern and Southern California. On the screen, you'll see 2 recent photos from events held both in Northern and Southern California. On the top left is a recent get-together at a restaurant in Pasadena for our Southern Council. And the bottom right is a picture of our Northern Council at a get-together in a park in the Bay Area to celebrate one of our founding members, Nancy, who's actually been around since all of this started nearly 30 years ago. The mission of the API Social Work Council is to advance the social issues of API populations and foster professional development through advocacy, consciousness building, education, political action, and community partnerships. Our contact information is in the bottom left, so please don't hesitate to reach out to us depending on where you live. We welcome both people who are interested in general membership and or participation in our steering committee, which for many of us can attest to has afforded really invaluable mentorship from social workers who have really paved the way for the work that we're doing today. It's truly an amazing group of people. Next slide, please. Just to get us started off with some learning objectives tonight. First is to cultivate a research-informed awareness of COVID-19 disparities impacting API communities. Second is to acquire up-to-date information about fall 2023 COVID-19 boosters and their importance in light of pandemic fatigue. Third is to learn best practices for promoting vaccine outreach, awareness, and uptake among diverse API communities. Okay. And to our main event, just to introduce our speaker tonight, Dr. Brandon Yan is MD, MPH, is a resident physician in the UCSF Department of Medicine, who's dedicated to providing high quality clinical care and bringing evidence to health policy reform. He earned his MD at the UCSF School of Medicine and trained in public policy analysis and public health at Duke and Harvard, respectively. Dr. Brandon Yan's academic pursuits broadly investigate how public policy can help improve healthcare access, value, and equity. Cited in major media, including the SF Chronicle, LA Times, US News and World Report, Newsweek, and Chron 4 News. His publications include those on COVID-19's impact on Asian Americans, Medicare Accountable Care Organizations, or ACOs, and cost effectiveness of heart failure treatment guidelines, US elections and mental health, and the Affordable Care Act's Medicaid expansion. His research was the first to uncover why reduction in deaths from Medicaid expansion did not translate into reduction in population mortality. He's led some of the first work on COVID's impact on Asian Americans and went on to impact public policy at local, state, and national levels. And Brandon also further consults on public health policy. So without further ado, I wanted to hand it over. Thank you so much, Dr. Yan.
Thank you very much for that very generous introduction, Victor. And let me start by extending my thanks to the API Social Work Council and the National Association for Social Workers California chapter, and all of the panelists and hosts here today for welcoming me and giving me this chance to talk a little bit about my research, as well as the fall COVID booster. I'm going to share my screen here to get started. And I'd further like to thank all of the attendees today on our webinar. I understand I have some stiff competition from a presidential debate, although I hear a couple of them have slimmer chances. Though you didn't come to talk to me about, to hear me talk about politics. You came here to hear me talk about the death toll of COVID-19 on Asian Americans, as well as the fall COVID-19 booster. So we'll get right to it. Again, my name is Brandon Yan. I'm at UCSF School of Medicine as a resident physician. I primarily practice in the hospital medicine setting for patients who are admitted, although I also have a primary care practice at San Francisco General Hospital. I also maintain research affiliations with UCSF and Harvard. The disclosures were mentioned previously. And my only other disclosure is I am just now recovering from what I think is the flu, which will also be relevant later in this talk. So great timing. Okay, so objectives today, we mentioned that earlier already. We'll talk a little bit about this research, the current state of COVID-19 vaccination, where we are today, and then the recommendations going into this fall for what we hear is in different terms, the fall COVID-19 booster or updated COVID-19 vaccine, with the latter being the more favored language, which I'll talk more about a little bit later. So I usually like to start this talk just with a thought exercise. I understand this webinar, so people can't jump on in, but one of the things I like to start by asking is, what have you all heard when it comes to Asian Americans and COVID-19? There's probably a couple of things that come to mind, and I'll fill in some of these blanks for you. One is anti-Asian hate, that Asian Americans have faced elevated levels of racism and discrimination in the face of a virus that politicians and others have used to foment hate. We may have also heard that when it comes to COVID-19, that Asian Americans did fairly well in terms of rates of infection and death, and therefore that this is not a group that needs to be prioritized or thought about at all when it comes to COVID-19 and public health measures. And that's in particular an area that we're going to talk a little bit more about today and debunk. Now, on that latter point, that Asian Americans did well when it comes to COVID-19 infections and deaths, they're likely referring to this data here that is through the end of 2020. That when you look at the cases of COVID-19 per 100,000 people in the population, Asian Americans have some of the lowest numbers, right? As you can see here on the left side of this chart here. Now, this chart actually disaggregates Asian Americans and Native Hawaiian Pacific Islanders. And when we see, and this will be a recurring theme throughout this presentation, is the importance of disaggregated data, we'll actually see that the case rate per 100,000 for Native Hawaiian Pacific Islanders exceeded that of all the other groups captured here in this analysis by Boston University and the COVID Tracking Project. That goes to show that when you aggregate them, you don't necessarily see disparities. And then when you look on the death side as well, you also notice that the rate per 100,000 people in the population for deaths is among the lowest for Asian Americans, and the rate for Native Hawaiian Pacific Islanders is also slightly below that of white Americans. And so people can look at this data and think about and draw their own conclusions. Some may draw simply the conclusion that Asian Americans don't face disparities and therefore do not need focus. We'll talk a little bit more about how this data point itself, while true, is incomplete, and that there are multiple other pieces of data that do suggest that Asian Americans did face an unusually high rate of death, but with a different measure. But I wanted to start here to bring us to what the popular discourse around this issue often is. Okay. So I'm going to talk a little bit about where my research started. And the reason why I go through this process is because part of giving these presentations is to inspire others as well to find ways to speak up and get involved in this type of work if and when and whenever people have either an interest or see something unusual or something unjust or inequitable in the world. This can be really anybody who does this work, and I'll show you why. So the way I started doing research in this area is all the way back in May 7th of 2020, when a good friend of mine and who ended up being a collaborator on a lot of this research, Fiona Ng, reached out to me and sent me this message saying that in May of 2020, there were 31 deaths in San Francisco from COVID-19. This is very early on in the pandemic. And among that 31 deaths, 16 of them were from Asian Americans, 16. And if you do the math, that's slightly over 50%, 52% to be exact. And nobody was talking about this in the media or really anywhere else. This was a statistic that had completely gone missed. And all night I stayed up thinking about this statistic and wondering what could possibly be going on. Now, obviously, these are small numbers, but in the world of public health, we strive to be a proactive force as opposed to a reactionary force. So anytime you see data that looks a little bit unusual, you have to ask the question of why and what can we do to intervene to prevent these numbers from getting worse. So that led to this initial publication. in the Asian American Research Center on Health, which is a research group led previously by Dr. Tung Nguyen, who I collaborated with on putting out this simple one-page publication. And the entire intent of this really was to draw attention to this issue that nobody was really talking about. We put this out there, calling attention to the fact that there seems to be this lopsided ratio of cases to deaths. So you'll see that among the total population here, out of 1754 cases, Asian Americans, or the overall proportion of deaths to cases, or the case fatality rate, was only 1.8%. But when you look at that rate for Asian Americans, it was 6.7%, about 3 times higher, a little bit more than 3 times higher, excuse me. And that got us really questioning these numbers. Why is it that when Asian Americans seem to have gotten infection, that their risk of dying was higher than everybody else's? You can see here much higher than really any other group. And initially, there was really no good way to analyze this because there was such sparse data coming out of the Department of Public Health. So we're simply asking for more data and calling attention. Some of these lessons that I'll show you relate to outreach today to the Asian American and Pacific, Native Hawaiian Pacific Islander communities moving forward with the COVID vaccine boosters. So one is getting the word out through ethnic media. Ethnic media is trusted in local communities. In fact, when you look at the studies of who do people trust the most for their sources of news, local media is in fact has the highest levels of trust among people in the United States when Pew Research surveyed them. And so we went on KTSF 26, and one of the ways that we knew that this had reach is that people, friends of mine, and actually my aunts and uncles, my barber, and my vehicle mechanic actually all commented later when I saw them in the subsequent months, say, hey, we saw you on TV. That shows you that ethnic media really has reach into communities that otherwise would not be reached by mainstream media. So we were on KTSF 26 among other channels. We were also our report was reported upon by the San Francisco Chronicle as well. And through this outreach, we were able to have our research report hit the desks of the San Francisco Board of Supervisors, which is the local city council, as well as the San Francisco Department of Public Health. And this started the conversation in San Francisco about what was going on with Asian Americans. Now, we were not satisfied with simply looking in San Francisco. We asked the question, if this is happening in San Francisco, is this also happening elsewhere in the country? Now, mind you, this is very early in the pandemic and very little was known. There was increasing research coming out about disparities impacting Black American, Hispanic American, and other ethnic minority groups in the United States, although very little had come out about Asian Americans thus far, in part because of the numbers that you saw previously. So we put out an expanded research article out in Health Affairs blog that looked at the Asian American case fatality rates across the country in some of the localities with higher rates of populations of Asian Americans. So you'll see that across the vast majority, if not all of these counties and states, we saw a higher case fatality rate for Asian Americans than for the overall population. You'll see in New York City, it was as high as 17.1% for Asian Americans versus 8.7% among the overall New York City population. And this was very early in the pandemic, where New York City was particularly hard hit by the COVID-19 pandemic. The same pattern was seen in Chicago, in Nevada, in California, and up and down this table. This analysis gave us more confidence that something was actually happening at a national level, not just in San Francisco, even though it was there that we noticed it first. So I'll talk a little bit about what we thought might have been going on. The question, of course, that everyone jumps to next is, why did Asian Americans face a higher case fatality rate? And the answer to that really comes in the form of understanding what the case fatality rate actually represents. It's the number of deaths over the number of cases. And so that's what we investigated next. We did a review article where we poured through the data in the literature to ask this question of why. Is this a denominator problem with the deaths? Is this a numerator problem with the number of cases? Or is it both? Now, the reason we chose to do it this way is that there was actually a lot of literature out there on the breaking down COVID-19 case and fatality rates by race and ethnicity. However, there's very little comment on on the numbers for Asian Americans. It was often sort of, if it had a line at all in the result tables, it was infrequently commented upon in the results with the discussion sections of the research papers. So our goal was to say, let's try to take as much data as there is out there, and let's focus on the lines that mention Asian Americans and pull that data together and see what patterns we can understand. And then talk about some of the data's implications. And we'll go through all of this together. It's going to be a lot of data, a lot of numbers. I'll try to make it as simple as possible and as not dry as possible. Okay, so this is actually a frequent question that we got, especially when we first published out in San Francisco, were Asian Americans really at a higher risk of dying? You know, I think this goes back to the model minority myth that I'll talk a little bit more about later. There was a lot of question about whether or not this was actually true, or if we were causing a stir for nothing. And to be quite frank, I don't think if this were another group that we would have gotten that level of skepticism in the beginning. So we said, well, let's see what the data says. We were open to the idea. In San Francisco, it was 16 deaths out of 31, small numbers. So let's look at really large samples. This is a Kaiser Family Foundation study using EPIC electronic health research data. And so this is analysis of over 300,000 people who tested positive for COVID-19. And what they found was, even after adjustment for multiple different factors, the risk of hospitalization for Asian Americans was particularly high compared to white Americans as the control population. And that difference was also seen in the risk of death. Asian Americans had a higher risk of death. And this is a very large sample. This is a Washington Post analysis. This one actually used CDC data. So they had even more cases to look at, 5.8 million COVID-19 patients that they looked at. And out of those 3 million cases, 128,000 deaths, Asian Americans had a 1.5 times higher risk of death than compared to white Americans. And this was, again, after controlling for comorbidities, age group, genders, and other potential confounders, that number actually went up to 1.6. And so, looking at these two large analyses, we were very convinced that what we had seen initially in San Francisco was not just a blip, and that there was a real difference in this case fatality rate, a higher case fatality rate for Asian Americans compared to white Americans, that is not explained by just race, or that is not explained, by age or other factors. Factors that were controlled for in those analyses anyway. So the other question too is, when you look at the case fatality rate, okay, it looks like the death number could be high. What about the bottom number? The bottom number is the number of cases. Could Asian Americans have been tested less than others, and so we therefore are catching fewer cases? There's some evidence to suggest this is the case. In the Kaiser Family Foundation analysis, they found that Asian Americans, among all the groups that were studied, had the lowest rate of COVID-19 testing in the population, 345 per 10,000, compared to 408 among white Americans, and higher numbers for Black and Hispanic Americans as well. So what this would suggest is that if we were catching fewer cases, our case fatality rate might be higher because we're not catching them. All right, So that might explain the bottom number, but for the upper number, why are Asian Americans at higher risk of dying? That was another big question that we had. And I'll pause just for a couple seconds for people to think a little bit about what they think might be the cause. So let's say the average Asian American showing up in the doctor's office or at the hospital or in the emergency room or at your friend's house seems to have a higher risk of dying when infected from COVID-19. Why might that be the case? It was a peculiar question that puzzled us. So this next study here in Circulation looked at a large COVID-19 disease registry from the American Heart Association. It provided us with a little bit of insights. In terms of presentation to care, so in the first line, days from symptom onset to hospital arrival, you'll see that on average, for white Americans, it was 5 days. And then for Asian Americans, it was 7 days. This would suggest that Asian Americans on average were presenting to care a little bit later than other groups may have been. Now, later presentation to care, especially back earlier in the pandemic when there were not therapies readily available, was associated with worse outcomes, being caught at a more severe stage, and having a lower chance of survival. You also see down here that timing of COVID-19 diagnosis. These numbers are a little bit closer, but the Asian Americans had the highest percentage of them that had COVID-19 diagnosed when they got to the hospital, as opposed to before hospital arrival. Again, this speaks to the data that we had seen earlier, that perhaps there was less testing happening earlier in the course of a patient's COVID-19 disease course, and then subsequently later presentation to care as well. What's particularly interesting is when we look at this particular model that tried to account for multiple different factors, because I'm sure as you're thinking about why would Asian Americans have a higher case fatality rate, socio-demographic factors would have come up as well. Things including income group, poverty rates, education level, as well as comorbidities, right? Asian Americans have higher rates of diabetes than some other groups. And so the question is, maybe these are and we know that comorbidities such as diabetes contribute to higher risk of death from COVID-19. So the research group, Rodriguez et al. In Circulation, looked at those questions and tried to adjust for all of those factors. So before adjusting for all those factors, Asian Pacific Islanders had a 1.1 times higher risk of dying than non-Hispanic white Americans. So I say, okay, it's not particularly different. In fact, the 95% confidence interval crosses 1, so you can't really say it's any different. You say, okay, maybe Asian Americans, they happen to be older. So because they were the folks who got COVID-19 were older, their risk of death is higher. Well, let's control for age. They controlled for age, and the odds of death actually went up. Meaning you control for that and saying, whoa, that's not what's going on here. In fact, that was masking some of the difference. And then you control for socio-demographic factors, some of those that we talked about. And that number continues to be high, 1.34. And then you control for medical history as well, and it keeps climbing higher, 1.5. And then even after you control for presentation features, it is still a 1.5 times higher risk, higher odds of death than you see for non-Hispanic white Americans in this large COVID-19 disease registry. What it suggests is that there are uncaptured factors here that are at play, and in the literature looking at health inequities, this differential that cannot be accounted for is often the question is what's left, and often what's left is racism, and we will talk a little bit more about that. The factors related to racism that are difficult to measure, truly very difficult to measure, but nonetheless play significant roles in the experience of minoritized groups in the United States, both in terms of their their health trajectory as well as their trajectory through multiple other spheres of life. Now, do I necessarily have the data to back that up? As I said, with racism, it's difficult to measure, but when you're starting to run out of other explanations, it's certainly one that cannot be discounted. It's one that you cannot rule out. We'll talk a little bit more about that later as well. And then another important question actually is looking within the Asian American population, what was the scale of mortality? And what I mean by that is, rather than simply comparing, or I shouldn't say simply, rather than comparing to other groups, looking within, what was the scale of mortality? It's a little bit hard to capture because COVID-19 cases were often missed, especially early on in the pandemic, and actually increasingly so now because cases aren't well tracked. We'll talk a little bit more about that later as well. So what the Marshall Project and the Associated Press did is they did an analysis looking at excess deaths in the population compared to prior years. What we would expect is in the trend line of deaths that it should be the exact same. Well, you might anticipate that it should continue along the same trends as before. And then whatever is in excess is something that would be attributed to COVID-19, either directly or indirectly. And so this is what they call excess deaths. And you'll see here that among the overall population, there was a 9% spike in deaths, 9% spike excess deaths compared to previous years. And among Asian Americans, that number was 35%. And this is one of the highest among all of the race and ethnic groups. So we know that COVID-19, either directly or indirectly, led to a significant jump in excess deaths in 2020 in the Asian American population. And then furthermore, when we look at the total number of deaths in Asian American and Native Hawaiian Pacific Islander groups, you'll see here that for the better part of 2020, 1 in 7 deaths among Asian Americans was due to COVID-19, and 1 in 8 deaths among Native Hawaiian Pacific Islanders were due to COVID-19. So these are significant numbers. These are numbers we don't want to forget. As we move further and further away from the pandemic phase of COVID-19, there's pandemic fatigue and there's pandemic apathy. But I think it's really important that we never forget the toll of the death toll of this terrible virus among our communities and in our shared communities that we are allied with, and those that are not Asian American or Native Hawaiian Pacific Islander. Okay, so I'll just go over some of the key points that I talked about here. So for Asian Americans, a higher or highest, in fact, risk of death from COVID-19 when infected, reflected in high case fatality rate, evidence of less COVID-19 testing and later testing, evidence of later presentation to care and greater severity of disease during hospitalization. So discussion on the role of racism. I talked a little bit about this already, but we'll kind of delve more deeply into this. One thing that's important is a point that often comes up, and I want to address is some people have brought up the idea that, well, maybe for Asian Americans, there may be a genetic role, that there's something about Asian race, despite it being a social construct that itself lends itself to a high susceptibility to severe disease from COVID-19. Now we understand race to be a social construct. Nonetheless, it was a question that we wanted to investigate in the data itself. And the reason we don't believe that there's evidence to this effect is that when you looked at the case fatality rates early in the pandemic in the United States, they were significantly higher than those that we saw in many Asian countries elsewhere. So if there was a genetic component to these numbers, we would expect to see some of these findings in Asian countries as well. And that's simply not what we saw in the data. And then with the model minority myth problem, many of you will be very familiar with this concept, so I will just go over it very briefly. It's coined in the 1960s by conservatives. It was a reaction to efforts to address institutionalized racism, and often it was used to pit Asian Americans against other minority populations here in the United States. And it was also used to exclude Asian Americans from education and research. And it continues to be a justification for the lack of attention and funding for Asian American issues to this day. And this is a line that we included in our paper, and I'll just read it here. The racism underlying the model minority myth harms Asian Americans by perpetuating the perception that they do not have disparities and therefore are unworthy of resources, which leads to a lack of data or inaccurate data for this population that then reinforces the misperception that Asian Americans do not have disparities. And I'll go over some examples of this. One is in research funding. There was a study done looking at NIH-funded research projects, and they found that those involving Asian, Native, Hawaiian, Pacific Islanders, or particularly A and HPI communities, were only 0.17% of the NIH budget between 1992 and 2018, despite Asian Americans comprising now more than 5% of the US population. So a significantly understudied group when it comes to at least research funding. And then I'll share a little bit more personally, an anecdote. The San Francisco Chronicle, as you saw earlier, had covered our research in San Francisco. And when I had first spoken with a reporter, this was actually what the reporter had told me. They had said, I actually had seen these numbers, the 16 deaths out of 31 total deaths, the weekend prior, when I had written a article on health disparities and COVID-19 in the San Francisco Bay Area, but I really didn't know what to think of it, so I didn't write about it. And as someone who actually reads the Chronicle every day, I also said, yeah, I read that health disparities front page article in the Sunday paper, and I was alarmed to see that there was absolutely no mention in this disparities article about the disparity, this jarring disparity facing Asian Americans in San Francisco. And I think what that goes to show is that model minority myth, that it's difficult, that it creates this perception of Asian Americans cannot possibly face disparities. And so therefore these numbers here, there must be some other explanation other than Asian Americans facing a true disparity. So that's a real way in which the model minority myth causes harm. And if not for the research that my team performed, it may not have ever reached the Chronicle or other groups. In the framework for equitable allocation of COVID-19 vaccines put out by the national academies, this publication, which actually I'm seeing here is quite expensive, made no mention of Asian Americans. And that was something that numerous Asian American and Pacific Islander advocacy groups called out the national academies for this exclusion of a group. Even if there was sufficient research to exclude mention of this group, which obviously after seeing all of this work here, hopefully you're convinced that that should not have been the case. There should at least have been mention and acknowledgement of this particular group that constitutes greater than 5% of the US population. But for some positive news, advocacy does make a difference. Some of this research that we put out was later cited by these excellent articles that I encourage everybody to read. One in USA Today and one in Scientific American that talked about the alarming rates of COVID-19 deaths among Asian Americans in San Francisco and elsewhere. And you see the left one attributing to racism and the latter one calling attention to how it's been ignored and that itself being a form of racism. So just to say that it may seem bleak, but there is work that can be done and that people are doing to draw attention and to change the status quo. Some of the barriers are being seen, and I mentioned language access. I didn't show, this is an area that has been under study as well, although there have been a couple studies to this effect looking at COVID-19 among populations that don't speak English as a primary language, and outcomes are worse for populations that don't speak English as their first language, including some of the Asian languages. There was a study out of Washington State showing that, as well as some others. Failure to recruit in studies is about representation in research studies, sometimes not even being included at all. early in the pandemic, there were some states that did not show data for Asian Americans or Native Hawaiian or Pacific Islanders at all in the race and ethnicity breakdowns of their data. And then, of course, aggregated A and HPI data. And that's something that I acknowledge myself as having been a major limitation of the research that we did. And we take of today's presentation as well. Okay, so I'm going to stop there for just a second to switch gears. I talked very quickly about the research that we had done previously. But that was then, and people say, well, Dr. Yan, it's now 2023, right? The COVID-19 situation is very different. There are vaccines now widely available. Rates of hospitalization and death are way down. So what does the COVID-19 pandemic, now endemic, look like? So we'll go a little bit into that data. So New York Times, August 2023 said, not over yet. Late summer COVID wave brings warning of more to come. There does seem to be a new wave of COVID-19 cases. Let's look at all over the world. There have been at least 770 million total cases of COVID-19. The number one region being in Europe, with new cases popping up. You'll see here, of course, that we have passed sort of the initial Delta and initial Omicron waves. And we are currently all the way down, close to all the way down here. But I'll show you some data that shows that COVID-19 may be resurging. So looking at hospitalization and deaths, this is largely a picture of good news. So if you look at over time, this is through the end of August of this year, hospital admissions have come way down from where it was previously during the initial Delta surge, and as well as the Omicron surge in 2022. And then we also see that the deaths have come way down. This is all good news, but you also see here, hospital admissions seem to be popping up just ever so slightly there at the end of August compared to earlier in 2023. The deaths seem to still be plateaued, although you might be, if you squint your eyes really carefully, you might see it pop up just a little bit. So these are numbers that the CDC and public health officials across the country are keeping an eye on. We'll jump here. So I mentioned a little bit earlier about how catching COVID-19 cases has been much more difficult. I myself, during my most recent, what I suspect to have been the flu, did multiple COVID-19 rapid antigen tests, and all of them were negative. To be quite frank, if they had turned positive, would I have shown up to the emergency room? Probably not. Would I have reported to anybody? Probably not, because how I would have handled it was stay at home, isolate, rest, drink plenty of fluids, take medications as necessary for symptom relief, and try to ride it out, because most cases now are pretty mild, and I myself am quadruple vaccinated. So what we public health officials now look to primarily to look at COVID-19 and where it is by looking in the wastewater. So in the wastewater treatment plants, this chart here, the best way to look at it is looking at the red, orange, and yellow. These are actually the red and orange levels. These indicate increases in the level of detected COVID-19. Yellow meaning stable, and the blues indicating reductions in levels of detected COVID-19. And you'll see that overall, there has been an uptrend towards the end of August 2023 of COVID-19 wastewater detection. So there may be a resurgence in our midst. And certainly in the San Francisco Bay Area where I practice, several hospitals have reinstituted mask mandates because of exactly this reason. They have noticed an uptick, not just in the wastewater, but also an uptick in cases in their own hospitals and their own employees. So we may well be in the midst of a minor surge that could be a major surge. We'll see. So the next question, of course, is where are we with vaccination, right? because the level of vaccination should correlate with our level of alarm. What we show here is this data from the Kaiser Family Foundation that as of January 11, 2023, so the beginning of this year, how many folks had received at least one dose of the COVID-19 vaccine. And we'll see here that for Asian Americans and Native Hawaiian and Pacific Islander Americans, the numbers are in about the 70% range. This is higher than we see in many other groups, although a little bit lower than among the Alaska Native and American Indian population. Nonetheless, when we look at these numbers, it is not only the disparity that matters, but the absolute number that also matters. Ideally, this number would be closer to 100%, but we have been at least at about 70% at the beginning of this year. So certainly more room to grow despite progress. And then, as many of you know, it's not just about the initial COVID-19 dose. What about boosters? Are people getting the boosters? And this data from the Kaiser Family Foundation shows pretty abysmal numbers. For that booster, for Asian Americans, about 20% have gotten that booster, and about 11% for Native Hawaiian Pacific Islander Americans. The numbers are across the board relatively low for all race and ethnic groups represented here. What that means is, especially for our conversation today, it means potentially a major challenge going into this fall 2023 season when a new vaccine is available. Let me talk a little bit about why this vaccine is so important. This is CDC data that, actually from the Commonwealth Fund here, published in the Commonwealth Fund, data estimating the number of prevented deaths, hospitalizations, and infections thanks to vaccination. And what we'll see here is the numbers are pretty staggering. More than 3 million deaths prevented in this period alone. This number is certainly higher as it doesn't cover 2023. More than 18 million hospitalizations averted, and more than almost 120 million infections averted through November 2022 alone. Now, these are large numbers, and these are the numbers that we wish were even higher, because as we know, deaths and hospitalizations have continued through this period. And these are largely preventable. Okay, I will also mention that I want to thank Dr. George Rutherford at the UCSF School of Medicine for providing me with some of these slides. He is truly one of the experts when it comes to infectious disease in the COVID-19 pandemic. So I want to express my appreciation for allowing me to use his slides. Okay. This brings us finally to one of the core parts of our presentation, of our talk today, which is about this updated COVID vaccine. Folks are asking, all right, you've convinced me that COVID-19 is important to worry about, that there are disparities that Asian Americans have faced, especially when it comes to the case fatality rates, and that the COVID-19 vaccines have saved many lives and prevented numerous hospitalizations. Now let's talk about what we do moving forward. Before we do, I'm going to take a quick water break.
Take your time, Dr. Yan. Feel free to hydrate.
Thank you. Hydrate, very important, not only when you are sick, but also when you're not sick. PSA for all of you out there. Okay, if you are still watching, feel free to take a sip yourself. I will take another sip.
We're on the edges of our seat.
Okay, that was not the intent, but that was a side effect. Okay, all right. This 2023 updated COVID vaccine. Let's talk about it. So it's a new monovalent vaccine that was just approved by the FDA for two manufacturers, Moderna and Pfizer. Both of these are mRNA vaccines, and the monovalent vaccine, updated vaccine, is now approved. Novavax has one that's currently undergoing FDA review, so I won't really be talking about that one. Okay, now the CDC recommendation, and I will put out a disclaimer that it's important that you talk with your physician or healthcare provider about whether and how many COVID vaccines you should get and during what time period, as the guidelines do vary according to multiple different factors. But I will tell you that what the general recommendations are. And that is for all people who are 5 years or older. I think that's probably most people, if not everybody on this particular webinar and people watching, or if you are less than 5, I do have some information for you as well. But for you, you should receive an updated dose of an mRNA vaccine that is either the Pfizer or the Moderna at least 8 weeks or about 2 months after your last COVID-19 vaccine dose. Now, one of the most common questions I get is availability. This vaccine is not available everywhere yet. In fact, in my own primary care clinic, San Francisco General Hospital, it is not yet available. The shipment is on its way, and so it should be available any day now. And as soon as it is available, and you don't have you are more than 8 weeks out from your last COVID-19 vaccine dose, I highly recommend getting this particular vaccine. And the reason for that is that this updated monovalent vaccine is specifically targeted for some of the new strains of COVID-19, the XBB lineage in particular. Some of you have probably heard about, there's so many variants out there with different combinations of letters and numbers. I personally can't keep up either. The biggest one circulating around the United States and across the world right now is EG5. And that is a XBB substrain. And this updated COVID-19 vaccine is effective against that particular strain. There is also, and I will talk a little bit more about that in a second. For people 6 months of age to 4 years, the recommendation kind of varies based on your prior vaccine history, how many you've gone before. There's a chart here that's probably pretty small on your screens here, which is why I recommend going onto the CDC website or talking to your healthcare provider about this. The recommendation is at least one of this updated vaccine, depending on your prior vaccination status. Now, I was talking a little bit about the variants. EG5 is the one that's spreading the most quickly. And as I mentioned, that is a strain within the XBB lineage that this new vaccine does target. Now, another one that people have been talking about in the media is BA.2.86. BA.2.86, you may have heard people say is very scary because there's multiple mutations and, oh my gosh, is this new vaccine going to work against this? Based on laboratory data that I've seen, that suggests that the new vaccine, the immunity generated from it does work against this BA.2.86 strain. Now, some of this is just going to be how does it play out as time goes on, as this new vaccine is uptaken by people. We'll see how things go. But based on lab data, it suggests that this vaccine does confer at least some immunity against this new variant with multiple mutations. Another common question that will come up is, if I recently had COVID-19, should I get this vaccine? And I will say that the guidance there, depending on who you talk to, is sort of all over the place. I will say that the good news is that despite having had COVID-19, and hopefully it was a mild strain for you, there is immunity conferred from it. And so depending on who you talk to, the recommendation is anytime to as much as 6 months out. The most number of people that the guidance that I've heard from the most number of people is generally somewhere in the range of about 2 to 3 months after having had COVID-19. That will give your immune system a little bit of time to rest before it is activated again from this vaccine. And so that's generally the guidance I have been giving to my own patients, is about 2 to 3 months after getting having had COVID-19. Although for patients who feel very strongly about getting it, I say that's certainly up to you. And there's nothing that there's no absolute contraindication to getting the vaccine after getting COVID-19 recently. And then for some folks who are a little bit more conservative about getting a vaccine, I'd say 6 months is not unreasonable to wait. The data does show that after about 6 months, the immunity, the antibody levels conferred from a COVID-19 infection tend to drop off. And so I also think that's a reasonable time frame, as long as my patient gets the COVID-19 at some point in that time frame. And again, there is a lot of discussion about exactly what the right time frame is for that. So I recommend having a discussion with your own healthcare provider about that. Now, you saw the numbers earlier about individuals, about pretty low uptake of the previous boosters for COVID-19. So in particular to our conversation today about the Asian American, Native Hawaiian, Pacific Islander American communities, the question is, what are the sources of vaccine hesitancy? Okay, this is data that I'm showing from the Asian Pacific Islander American Health Forum, which is a really fantastic group, as well as the COVID Collaborative and Heart Research. They did a survey asking exactly these questions. For the people who are hesitant about getting the vaccine, what are the reasons for hesitancy? And the number one reason for those who are hesitant is that they're afraid that a vaccine is not safe, that they're afraid of the side effects incurred from it. And let me just briefly address that question. So most, as you saw, the vast majority, over 2/3 of Asian American, Native Hawaiian, Pacific Islanders have received at least one vaccine. And what I often say is to my patients is, you are still here right in front of me after receiving 1, 2, 3, or 4 vaccines. And that tells me that this vaccine, you have tolerated this vaccine, at least without a side effect of death. So we've ruled that out. And I will ask my patients, well, what side effects did you have? And most commonly I'll hear, oh, I had some arm soreness. I had flu-like symptoms for about a day or two, and then that was it. Well, for those patients, I have good news for you. The data, at least from the Moderna vaccine that I reviewed, this updated booster, or I shouldn't say booster, updated vaccine, actually shows that there are lower rates of side effects. So the rates of fever, headache, those flu-like symptoms are lower than what was observed in prior vaccines. And so if you had a mild reaction to your previous vaccines, chances are you'll probably have a mild or even milder reaction this time. The point about myocarditis, the risk of myocarditis is near zero. Out of, gosh, I have a number somewhere. The numbers of people who had myocarditis numbered slightly in less than 2,000 out of hundreds of millions of doses given out. And so it is a number that's next to zero. And part of the guidance to wait at least 8 weeks in between vaccine doses was that seemed to reduce the very small risk of myocarditis to even smaller. And then to the second point, I won't go through all of these. Vaccines won't be effective against COVID. Well, hopefully the data that I presented today shows that with the millions of deaths prevented and the millions of hospitalizations prevented, that at least when you look at the data that scientists have looked at, that it seems to be effective. And not only that, but that with this latest COVID-19 vaccine, a lot of people say, well, this one will be effective. Well, at least from the lab data that we've seen, it works against the particular strains. And so, in fact, people will say, I have already had the prior vaccine. I don't need another COVID-19 vaccine. I'll say, well, actually, those are the ones that actually might not be effective against COVID. So if you're worried that it's not going to work, you should be worried that the ones you had before were the ones that might not work against these newer strains. And in fact, this newer updated COVID-19 vaccine is exactly what's going to work. So that's another point that I make to patients who simply say, I don't need another one. It doesn't work. I had COVID last time despite the vaccine. And that's another important point, that these vaccines are designed to reduce the severity of COVID-19. It does prevent some cases, but the expectation is not that it's going to prevent you from having no risk of having COVID-19 at all. In fact, it won't. For the main benefit of is reducing your risk of death and hospitalization and having a severe case. Okay, I've talked quite a bit about that. Let me spend just a little bit of time talking about some other vaccines that we shouldn't forget about. The influenza vaccine. The flu season is upon us. I may have just gone the flu myself, and the flu vaccine just became available where I work, and I hope it'll become available everywhere else soon. So make sure you get that. And this is actually a point of counseling for patients that I think is very helpful with the COVID-19 vaccine as well. A lot of patients will say, I had a mild case, I don't need the vaccine. Convince me, doc. And I'll say, one of the strongest emotions known to humankind is regret. And I would say, I don't want you to be that person who's going to regret not having gotten the vaccine when you get COVID-19. If it's a severe case, I certainly don't want you to regret not having had the vaccine. And even if it was a mild case, I certainly would rather not have a mild case of COVID-19 than to have had a mild case of COVID-19. And if all it takes is one shot, then if it were me, I would say, give me that shot. That'll help reduce my risk of infection, hospitalization, and death, so that I don't have to regret not having to have had it later down the road. And I say the same for the flu vaccine, and I kind of wish I had gotten that before I had contracted what was likely the flu myself. But I think may have unfortunately had the flu a little bit early in the season. Okay, and one other vaccine I want to talk about is RSV vaccine, respiratory syncytial virus. This causes a bronchiolitis, typically seen in kids or older adults. This vaccine is available now for adults greater than 60 years old or at 32 to 36 weeks of pregnancy. So if you're in those categories, I do recommend getting these vaccines. And there's no absolute reason why you can't have all three vaccines at once. Although for patients who are often don't want to have that many vaccines all at once, I say, no problem. We can schedule you to come back in to get this vaccine at a later time. Okay, I've spent quite a bit of talking. Before I hand it back to our wonderful host, I just want to thank again the API Social Work Council, National Association of Social Workers, California chapter. I want to thank Victor, Ayaka, Jeff, Sylvia, and the entire team for putting this event together. My contact information is there below. In case you have additional questions, I will preface and disclose and preface saying that I is not your healthcare provider, as far as I can tell from anyone on this webinar. Don't see it as I will not give personalized medical advice, but feel free to reach out if you have questions. And my Twitter there is BN415. You feel free to follow me. I tweet on a variety of random things if you're interested. And I'll just leave my PSA there to get your vaccine and some of the recommendations there. I'll hand it back to you, Victor.
Wow. Thank you so much, Dr. Yan, and for just going over all that information and talking to us about the sort of triple crown of vaccines this fall. I heard you use the word dry earlier, but I think that the research that you afforded and the insight you afforded was anything but dry, especially for all of us public health nerds out there. As social workers, we oftentimes, will embrace an awareness of healthcare as a cultural construct. And your research, I think, and presentation really opens the door for cultural humility and shines a light on the disparities that have remained hidden within the dominant constructs. I'm hoping that everyone will take this talk with inspiration and, have a deeper dive into how it might apply in your own work and allow for introspection as social work professionals. Moving on to this next section of our webinar, we'll be interviewing Dr. Yan with some questions that we've prepared. How are we doing on Q&A questions? Want to encourage all participants to type in their questions so that we can use the time at the end to share those as well. And for the first question for this interview, I wanted to go back to your research with ARCH in 2021. It was really, really groundbreaking and invoked, for many invoked a sense of urgency around COVID-19 outreach and support to API communities. Like you referred to earlier in your talk, fast forward 2 years later, the same sense of urgency, feels like it's waned a bit for fall boosters, both patients and for many social workers alike. And I'm wondering, what kind of advice would you give to those who say that the risk of COVID-19 is a non-issue in 2023? For example, they might cite, the lower excess deaths and say that it's a non-problem, or might consider vaccination to be a non-issue, just like they consider masking and distancing to be a non-issue.
Yeah, absolutely. I think that's one of the key challenges that we face both in as clinicians and in public health is this apathy and the fatigue with the pandemic, as you mentioned, and how we can effectively promote the COVID-19 vaccine. And I think the strategies that I think of, and some of them that I've mentioned, is spending time with patients individually and talking about their concerns, right? It seems that the concern about deaths and hospitalizations has gone down. And it's actually an important opportunity to remind patients that is a direct result of the fact that we have had really great vaccines, and that enough of the population has been vaccinated to help bring numbers down. And to remind folks that COVID-19 continues to mutate. It's a ever-evolving virus. It's not going to go away. It's endemic, and in fact, that's the natural history of these viruses. And so, if we want to maintain that same sense of assurance and even apathy towards COVID-19, we have to remind ourselves we want to get out ahead of COVID-19. We don't want to be where we were in March 2020 when we didn't know what was coming, and we were hit by surprise. We want to get out ahead of it, and the way we do that is by being vaccinated, right? I can bring up, for instance, smallpox. But we know vaccines work because we actually eradicated smallpox through vaccination. Now, I don't want to give anybody the expectation that we're going to eradicate COVID-19 through vaccination, but the point is that to have this level of privilege, really, to not have to worry at all, worry about the severe side effects the severe effects of COVID-19 is all thanks to the vaccine. And so we need to continue to be updated on our vaccines so that we can continue to have this level of assurance, not only for ourselves individually, but also for everybody else around us. And this is not just for us. Maybe the risk of COVID-19 is low for a young individual, but a young individual may be around people who are immunocompromised or older, for whom even the vaccination, the immunity does not last quite as long. And so not just for ourselves, but for everybody else around us. And I always like to bring that regret part up, as I don't want you to have regret one day for either for yourself or a loved one having not had your vaccine.
Thank you so much for that answer, which really helps us, understand not only how to combat the fear of the vaccine, but indifference around the vaccine. Our next question is, about some of what you're seeing as a physician. If you could tell us a little bit more about what your, what's the current impact of COVID-19 on API communities, and what we know about both the short and immediate health consequences, and also some of the long-term concerns.
Yeah, and what I can say about that is that overall there seems to be a little bit of a surge in COVID-19 across the country, including here in San Francisco. Specifically for the API community, seeing similar upticks, at least in my conversations with colleagues. I will also say that there is a wide degree of reactions to this uptick. There are some folks, especially some of the younger folks, and this crosses all the racial and ethnic lines, who are much less concerned as compared to some of the elder folks that I speak with, who are a little bit more eager actually for the vaccine. And unfortunately, it's actually not yet available in my clinic anyway. Although it may be available at others. It's arriving any day now, as I mentioned. And I really think that this, at least when it pertains to the API community, it's a reminder to reflect on on how far we've come. As you see the numbers with COVID vaccination being on the higher side, but certainly not where we would like it to be, and that this is an ongoing community-based discussion that we should have. That the same interventions that we had in outreach should be things that we don't let up on. For Asian American, Native Hawaiian, Pacific Islander communities, and really all communities, as we undergo this fall COVID vaccination campaign.
Thank you so much for that. And this next question, and I admit I'm a little biased as someone who works with children, so I may have bumped it up higher in the order of questions. But for social workers who specialize in working with children, youth, and families, one thing that's really cool about this round of recommendations from the CDC, it's very straightforward and very simple. And if social workers are encountering children, youth, and families and having vaccine dialogues with them, what are some of the common concerns that you might see as a physician around the COVID-19 vaccine for families with younger children, and maybe thoughts on how to meet and ease some of these concerns?
Yeah, absolutely. And I think and that I will preface by saying I myself do not see patients who are on the pediatric side. I take care of adults only. Although some of the concerns that come up are similar, if not more elevated, because it pertains to children in particular. And I will say that those concerns are similar to what we saw earlier in this presentation. The number one is safety. Parents, guardians, loved ones, their number one concern is this vaccine safe for my kids? And I think the best demonstration of its safety actually is in seeing the millions of doses that have already been given, and its safety and effectiveness pretty much across the board, the experience that we've seen already. And the fact that for the numbers with this updated vaccine, at least the Moderna numbers that I've seen, the side effects being even less than what we've seen before. So I would say our past historical experience is our best indicator actually of how things are going to be moving forward. And really the big one that often comes up is the myocarditis piece, and which is why I brought that up earlier. That seems to be the one that seems to be more common among young males, age 12 or so to the upper 20s. And I want to acknowledge those fears, that yes, in the studies, it did show that across the population-wide studies that there was an elevated risk in young males versus other groups. Now, I want to put that in context that the rate I calculated, it was a 0.0005% across the population, and I think a smidge higher than that among the young male population. And so the mitigating factors that I mentioned, making sure that you space out your vaccines at least 8 weeks apart, that seems to mitigate that small risk even further. And also putting things in context, as I mentioned, that this is a very small risk. It is true that it is there, and I don't want to discount it as well. But overall, that the risk remains exceptionally low.
Thank you. Yeah, it sounds like, relative to many of the other things that people regularly do on a day-to-day basis, the risk is just so incredibly low, and these vaccines are incredibly safe and effective. And the next question goes back to what you were sharing about with the interviews. It was really awesome to see you highlight those experiences, because in social work, we have this concept of meeting clients where they're at. And your KTSF interview and your use of social media is a really great example of that, because I think a lot more API communities, for example, in San Francisco, got exposure to your work through the KTSF segment, as opposed to CNN or other major news stations. And I'm kind of wondering, how can social workers adapt and apply some of these strategies at a grassroots level and in the work that we're doing within different practices?
Yeah, absolutely. And I want to start actually by thanking all of our social work partners across the country for the extraordinary work that you all do. And it really is an honor here to be invited to speak in front of all of the social work professionals and admire all the work that you do. And certainly in my work in the hospital and the clinic, such incredible partners. And I will say, oftentimes on the clinician side, we often don't have nearly as many touch points with patients as our social work colleagues. And meeting patients where they are, social workers often do a much better job of that than we do. We are often very focused on the medical and the science and the biomedical side of things. And for social workers, one of the key things is to understand the context from which patients are coming to clinic or their perspective on life. For instance, when they see me in clinic, my goal maybe I just want to get this vaccine in you and see my next patient. And for a social worker, they may be evaluating the patient a little more holistically, saying what's the most important things that are going on. For instance, it may be food insecurity. And those are things that, for instance, I actually have very few resources to look into. And so meeting patients where they are, as you mentioned, understanding where they're coming from and being able to, through each interaction, meet them where they are, address and try to address the needs that are most important to them. And then also through building that trust and that relationship with patients, be able to bring the COVID vaccine into that conversation through someone who is trusted and as a source of information, as a source of health information, including on the COVID-19 vaccine. I often think about patients who are discharged from the hospital. I often don't really hear about the patient afterwards, but our social work colleagues will follow up. And in those conversations, being able to bring up the COVID-19 vaccine and introducing resources for where to obtain that vaccine as ways that social workers can play profoundly important roles in this campaign. And even beyond that, just as human beings, whether we come from a health background or not, speaking up when we see unusual statistics, when we see things that seem to be unjust or even just unusual, right? All of us possess the capacity to speak. I know, the world is unjust in whose voice counts more or less, but we all have the capacity to speak in our own ways to advance justice. And in one of those ways, it is in encouraging vaccine uptake to protect our communities.
Thank you so much for shining a light on that. And, speaking of those resources, at the end, we do have a link to the Bridge Access Program, which is a way that uninsured and underinsured folks can kind of research where to get the vaccine with limited resources. And you mentioned a little bit for our next question, you mentioned a little bit about working on a team. And so for social workers who are working alongside doctors and nurse practitioners, in kind of this transdisciplinary environment or interdisciplinary environment, when you, let's say if you're in clinic and you're doing a warm handoff to a social worker, what would be the typical goals of this warm handoff that you would hope the social worker can sort of take as a fellow team member?
Yeah, that's a really great question. In my experience, and it's mostly in the hospital setting, we call upon our social work colleagues for multiple areas of support, in particular, including housing, food security, with accessing legal support and help, and resources to thrive in the community after they are discharged from the hospital. In the course of these warm handoffs, our goal is to make sure that that patients are not lost to care. That we know that these socioeconomic factors outside of just biomedical disease processes has such a profound impact on health. And so these are areas that our social work colleagues are professionals in and have. And really, it comes down to I think what our colleagues do really well, which is to be deeply rooted in the communities, to know what resources are there and which resources are most culturally and most culturally appropriate for our patients, so that when they leave the hospital, they are well supported by groups that they trust and have access to resources to help them thrive. And because he's truly, one vaccine is not going to do it all. It's a whole array of resources that really enables people to thrive.
Thank you so much. You really highlight so many important points, including, how, motivation oftentimes, exists and grows within the continuum of care, and how important that teamwork element is.
So,
and, for our next question, you had, mentioned this idea about barriers to being seen, such as language, failure to recruit in studies, lack of disaggregated data. When it comes to public policy and advocacy, I'm wondering, how can social workers dismantle some of these barriers that keeps so many API communities hidden within our respective settings, whether or not we're working micro, meso, or macro level practices?
Yeah, I think that's a really important question, and something that we think a lot about as physicians as well, is how can we be the best advocates possible for our patients and our clients. And I think at all of those levels that you mentioned, right, it can be at the individual level, right, that whether it's physician or social workers, that we hold professional titles that bring us some level of authority in the way that we can advocate for our patients. So whether it's advocating before our own colleagues or with outside groups, I would say that it's putting our hearts into it, which can be very taxing, and burnout is a real thing. It's a really challenging thing affecting all of our professions here. That we do try to put that in for each individual patient, to tailor our advocacy for them, so we can get them what they need. And then at the more macro level, thinking about structural changes, because as we know, where our patients and clients end up are often, and actually more often, not due to individual choices, but also those structural factors that predispose people to the situations that people end up in. And so those are hard. Those are hard to combat, right? And that takes, in my view, coalition building. That's the most important thing, building coalitions, right? It's not a marathon, because if you run a marathon there, it's not going to work. And I've seen so many colleagues leave the field because of that. And so it's running a slow race together with your colleagues and your partners and even the people who disagree with you, right? Growing this movement together, so that ultimately we're not leaving folks behind, or at least doing our best not to leave folks behind. And this advocacy can, it may sound kind of abstract, but it can take the form of something very apparent, like a rally or speeches. But it can also be more quiet, in the form of letters, as in, and in my advocacy work with local legislators, those letters actually matter. People, they read them. They tally up how many letters they get in support of this and against that. And over time, that can make a difference. And elections matter. I always say that as well, without getting too far into politics, but getting involved in areas that we very much are professionals and know more than a thing or two about, to get involved in those areas of social policy.
Thank you. And I don't think you have to worry about getting too far into politics with a group of social workers.
Yeah.
But definitely would love to learn more about that in the future. For our last question, I wanted to finish us off on a positive note, because our profession identifies as a strengths-based one. And I wanted to ask, what are some of the resilience factors that you experience and you see on a day-to-day basis as a physician when it comes to COVID-19 and API communities?
Yeah, absolutely. And I'm really glad that you brought up that question, especially for the last one, because it just brings me so much joy to talk about some of these things. I will say amongst my patients in the AA and HPI communities and even my own family members, I just recognizing the resilience that they come in with already, right? All of the struggles and challenges that they have experienced, both whether they are first generation immigrants, overcoming the struggle that is immigration itself, being a huge challenge barrier that they've already overcome, and as a source of strength. You often actually hear from some of the elder patients or family friends or such talking about, oh, we've been through worse. we've been through a lot, right? And just to scrape by and just to make it today, and hearing those stories of how they've overcome and triumphed in the face of the challenge as immigration, and also living and growing up as a minority in America, right? Whether you're first, second, third, or whichever generation may be, and having that unique experience growing up and those unique challenges, recognizing how far one has already come. And then one thing that always brings me joy also to talk about ethnic enclaves is, and there's a colleague who has been doing research on this, that health outcomes actually seem to be stronger in ethnic enclaves. And these enclaves, whether enclaves by choice or enclaves by discrimination or redlining, right? They seem to be protective, that when communities of color stick together and support one another and help each other out, that they seem to do better on multiple health outcomes. And so thinking about how this sort of unity, right, that we have together, and again, some by choice and some by structural racism, has found its way to be a source of resilience. And so I always enjoy talking about that and reaching for that, as your community is a source of resilience and strength.
Thank you. I really wish we had a part 3 to this webinar series. Out of the interest of time, I'm going to turn it over to Jeff for some of the Q&A questions. Do we have?
You know what? I think there's a couple that may have been answered live, but one final one that we could just get through real quick is, someone asked, medically, what are some conditions that have been seen to co-occur with COVID illness or be exacerbated by COVID?
I see. So you're talking about, the question is about comorbidities that seem to be associated with COVID-19. Now, there's without having more specifics about that question, there's a couple ways to approach it. One is, in particular, I suppose, susceptibility to COVID-19. And for that, it's primarily patients who are immunocompromised. So patients with HIV/AIDS, patients on long-term steroids that are immunosuppressive, or other immunosuppressive agents as well. Those are conditions that predispose to susceptibility to acquiring COVID-19, as well as a reduced immune response to the COVID-19 vaccine. In terms of risk of severe disease, there are multiple conditions that seem to be associated, diabetes being one of them. There are so many that I hazard to even think about it. Any sort of pulmonary condition also predisposes to more severe disease. Although, fortunately, with the more recent strains with the Omicron strains, it seems to be targeting more the upper respiratory tract as opposed to the lower respiratory tract being the lungs, and causing pneumonia, which was the case with earlier strains. And so, any sort of respiratory condition can also predispose to more severe disease. And of course, another associated comorbidities, there may be underneath, there may be a question about long COVID. That's really something that's still relatively unknown. Most of the studies there are on associated conditions as opposed to treatments, although there are some trials underway for treating long COVID. We truly do not know what those treatments will do. We'll just have to wait to see the data. So because I didn't quite know which segment of that you were asking, I kind of went for all 3.
Great, thanks so much, Dr. Yan, for answering that. So yeah, just for the sake of time, we'll be wrapping up now. And so on screen are listed some resources. Connect to End COVID-19 is the CDC grant project that funded this webinar. There's the CDC Bridge Access Program that Victor referenced earlier, and then there's CDC resources in non-English languages. Next slide, please. Okay, and then so finally, this is the information on securing your CEU. You just have to submit an evaluation survey And I believe Sylvia just posted that in the chat. So you can take a moment to open that up. And I just want to say thank you so much, Dr. Yan, for your work in this area and also for your time in presenting tonight. Thanks so much, Victor, for leading this project. And also thanks to all the other consultants here and the NASW California chapter staff who've really supported this project. So with that, I think we're done.
Well, thank you very much for having me.
Thank you.